Hello.
Yeah, thank you. So,
Okay, we are here. Suresh
Dr.
is here.
Sinha, go ahead. It's all yours.
Sorry, we had a problem in connecting. I'm
That's
sorry.
fine. Go ahead.
Okay. Thanks for joining. We have a very good, distinguished speaker today to discuss about the update and current status on COVID-19. We have a Pradeep Shah. He is board certified internal medicine and infectious disease. He's a personal friend. He is president of the medical staff at JFK. It's a Hackensack Meridian JFK hospital system. He has been in the community for very long, and he has been recognized. He has treated hundreds and hundreds of COVID-19 patients at JFK Hospital. He's also part of our New Jersey state API. He's a general secretary. He has been active locally in API and promoting API. So I welcome Dr. Pradeep Shah. The other speaker we will introduce as we go along. So Pradeep, you have about 15 to 20 minutes to give a talk on testing and tracing of COVID-19, current situation, and please go ahead. Did you unmute?
Yeah. Can you hear me?
Yes.
Okay, so thank you, Dr. Sinha, for introducing myself and that. And thank you, everybody. I welcome every guest and everybody. Welcome as we are in the different era before the COVID-19. The COVID-19, what I have labeled them is a enemy, invisible enemy. We know that this virus is there, but we don't know where and what. We only know about this virus tip of the iceberg. We still have to know whole iceberg. We don't know. So whatever I say today, it may change in the future, but whatever up till now we know, we can talk. So let's start with the COVID-19, which is a COVID-2, also called COVID-19 2. So basically this disease, which we all know, started from Wuhan in China. And there is controversy about whether it came from animal or man, or there is some all different theory. I'm not going to go, but let's start about talking about the USA, which we started to see in some February. And in Northeast, it started in about February end to early March. And in New Jersey, where I practice, is Edison, New Jersey, where it started, we started seeing the patient on March 11 to 12. And within a week, we realized that there are so many patients with COVID-19 came, and it was a disaster or very difficult to deal, but we'll keep that aside and let's talk about the testing, what we are told. So as you know that COVID-19 is a coronavirus. Coronavirus has been there for a while, but this COVID-19 had mutated, and usually coronavirus remains in upper respiratory tract infection, but this mutated virus goes into your lung, into alveoli, and damage your lung. There is a lot of cytokine storm, what we call it, and causes the damage. And that's where the problem comes because of the oxygenation. And we have been treating different ways, and all that treatment is a different story. But let's start with the testing now. The testing, initially, we had a difficulty in testing because we were not prepared and all that, but now we have a testing. The testing, there are two different testing. One is called the virus testing, which is antigen testing or RNA testing, and another is called antibody test. The antigen test has to be done in proper way. If you don't do the proper way, the swab, you really literally has to put in deep into the nose until patient sneeze. Usually that's what patient feels something is there in your nose. If you don't do that, the test may not come out positive. So sometimes we had a problem with initially the test was not done properly. Also, there is another test called sputum test, which is also there. This is also antigen test. Now bear in mind that antigen test can remain positive up to 3 months, because what we are testing is RNA virus. RNA of the virus. Now it can be dead virus or it can be live virus. There's no way you can decide on the antigen test whether that was a live virus or dead virus. So sometimes people ask me, well, how come I'm positive after 3 weeks, 4 weeks? Yes, it can be up to 3 months positive. So positive, once you are positive, antigen test, I don't think it will help you to differentiate between live and dead virus. And you can be excreting the virus, dead virus also. So that is the antigen test. And bear in mind that the virus antigen also there are different tests and sensitivity and specificity of the different lab difference than the what initially were done. So you may be seeing the sensitivity and specificity of the different lab tests. Though nowadays most of the test is sensitivity up to 95%. So negative RNA or PCR, whatever you want to say, antigen test, negative does not rule out. If you have a strong suspicious for the COVID, and if you cannot explain any other symptom due to any other disease, you can still assure that you can repeat after 24 hours or 48 hours, or treat the patient accordingly. If patient is sick, very sick, you don't want to waste time and you can start the treatment. Though treatment also is very limited, but you can start the treatment. The other test is antibody test, which is very interesting in the sense that this, as I say, this virus has defied all the medical rules in the sense that whenever there is any disease, you start with IgM production, which is usually within 2 to 4 weeks. And then IgG comes after 4 to 6 weeks positive. But this virus has sometimes IgM is first comes, sometimes IgG comes. So it's a two different things. So usually I recommended to do total antibody, which includes IgG and IgM. If you do only IgM, sometimes the people don't respond to that IgM. They don't make it IgM initially, and it will be false negative. If you do only IgG, it can be false negative too. So if you do the total antibody, which may be accurately replace whether IgG or IgM, the question is then you cannot differentiate when patient had this disease also. So the main message for this virus is you do the both IgG and IgM or total antibody, which will help you to diagnose. Now people ask me, why should we do the antigen test in an asymptomatic patient? Because the people who are in frontliner, who has doctors, nurses, police department, or EMS people, they want to know if they are positive antigen test, they need to be isolated for 14 days. Of course, now saying that WHO has come out yesterday, something different, which I will leave aside right now. We won't talk about that right now. But the idea of asymptomatic antigen test to do is the people who are frontliner today, if they have it, they cannot, to protect the patient or also other people, you want to do that testing to the antigen test. Antibody test will tell you whether you are exposed or not. Sometimes it doesn't tell you when it was exposed or anything. So you can still do the testing. You can still do both the tests, but it's going to be very difficult to interpret sometimes. I have people coming to me in the first week, the first time their symptom is positive. After 2 weeks, it become negative, and then they did third week, the antigen came positive. Yes, that can happen because you're talking about the RNA virus, which can be dead or live virus. We don't know. We cannot make out on the antigen test whether it's a dead or virus. If you are excreting dead virus, sometimes it can be positive, sometimes it can be negative. So that's the reason people have it. So once you have, after 2 weeks of the, if you had a positive first 2 weeks of the disease, after that testing may not help you except in certain area where patient is exposed, like some people can get exposed, like a surgery, tracheostomy you want to do, any surgery you want to do, that may help you to prevent that spread of the disease. But by just doing the antigen test after 2 weeks, it may not help as long as you know that in first 2 weeks you were positive. And then the other remaining is antibody testing. Why should you do in the public area? Why should you do the antibody test? There are many reasons to antibody test. That is, one is called the herd immunity. Herd immunity is we want to see prevalence of the disease, how much was in the past, and how many people have a positive antibody. So that's the one reason you can do. And epidemiology knows more about the herd immunity to know about the the antibody testing. The other thing is the healthcare worker, the frontliner, all people, sometimes they want to know whether they were exposed or not to have an antibody test done. Like we have a 17 hospital in the New Jersey, it's called Hackensack Meridian. We started doing the testing of the all the employees, what we call it team member, including doctor. We had a less than 1% antigen positive in our group of the doctors and all our employees. We are talking about quite a bit employee we tested. And the antibody test was only 13% positive. So doing that test is not going to help you. So in that region, they have stopped doing the test because the positivity is very low and antigen is only less than 1%. The idea was to do the healthcare employee, the testing was because they can not give it to the patient. And as we all know, that we always protect our patient, particularly the people who are immunocompromised, chemotherapy, radiation therapy, or end-stage renal disease, diabetes, COPD. All these people are very high risk to get this infection, and they deteriorate very quickly. In order to prevent that spread of the disease, original idea was to do the antigen testing on the healthcare worker to prevent the giving the disease to the patient. But the positive test is so low, so they are not doing anymore right now because it's a positive rate is very low. And I believe that in the future, we may have a better test or whatever it is we can do, or herd immunity is the one way to know how many people were exposed, how many were really has a disease, or how they are infectious or not, we can always see. We still don't know whether the IgG and IgM cutoff level to be positive. They have just done the arbitrarily, so we don't know. So to say the patient that patient is immune is very premature to say at this time because we don't know what is the cutoff level. To give example, hepatitis B, when we give vaccine, you have to have a level of 10 to be immune. If you have less than 10, you are not immune. But this disease, we still don't know what is the cutoff level to be immune. And only time will tell. And hopefully we'll have this disease, we'll know more about that and we will do the testing. I believe that's what I want to say this time, about the testing. Dr. Sinha. Hello? Hello? Can you hear me? No. Yeah.
Yeah, he's.
Can you hear me now?
Yeah.
Okay, I was trying to unmute myself.
Yeah. Okay.
Okay, so I think thank you very much, Pradeep. It was a good talk, and we will get a Q&A, some questions. The next speaker is going to be Pooja Shah, and Dr. Kavadia is going to introduce her to the group. Kavadia? Vipul?
Yes, this is Vipul Kaparia from Tampa, Florida.
It's a pleasure to introduce Dr. Pooja Shah, a young physician at a very young age, has been able to become a principal investigator for the remdesivir expanded access program at JFK University Hospital in Edison, New Jersey. Dr. Shah is a medical graduate from St. George University School of Medicine in Granada and did her residency at St. Michael Medical Center in Newark and did a fellowship at Vincent Medical Center in Greenville. She's currently principal investigator for the expanded access program for remdesivir at JFK University Hospital in Edison, New Jersey, and she'll talk to us about the treatment. Thank you.
All right. Good evening, everybody. Thank you, Api, for having me here. It was said that I was the principal investigator for the remdesivir expanded access program here at JFK Hospital in Edison, New Jersey. So first off, remdesivir is one of the trial drugs that were put out for possible treatment for COVID-19 patients. Remdesivir itself is an inhibitor of the viral RNA-dependent RNA polymerase with inhibitory activity against SARS-CoV-19. Remdesivir was initially used for Ebola back when we had the Ebola outbreak, but now they've been doing studies about using it for COVID-19 patients. So at our hospital, we were one of the sites to have expanded access. So what does that mean? We were able to get the drug for our patients. We had a strict criteria. It was mainly for the intubated patients. We had a strict criteria, and so they had to be intubated. They had to have normal kidney function, and the liver enzymes had to be within 5 times upper normal in order to enroll these patients for the remdesivir. Now, you have to understand, once patients with COVID were intubated, they actually ended up having mortality rate was higher. So we were very cautious in how we used the drug for our patients because they were already sick from the beginning. So we enrolled about 63 patients in our hospital to give the drug, and about a handful actually did come off the vent and did good from our experience. As it was mentioned now in May, it turned into emergency use. So our hospital was doing emergency use along with expanded access use, which was great. So the emergency use we were able to use for our non-intubated patients. Anybody who had oxygenation less than 94% was a candidate, normal kidney function, and their liver enzymes had to be 5 times upper normal here. Now, remdesivir was one of the treatment options we were able to give our patients here. There were some side effects you had to be worried about. One of them was liver failure. Another one was kidney failure. And then some people would get some transfusion reaction we have seen, or fevers. And that was the main things we would monitor for our patients here at JFK. And so the remdesivir, there's been a lot of articles out about what its useful is. It is shown to decrease the length of stay in the hospital. The remdesivir was helped to, if patient was supposed to be with this disease, they would be in the hospital for many days. So they think it would help decrease their length of stay in the hospital with the drug. And that's why we've been offering it to all our patients. And that's about it.
Oh, thank you. So you are keeping, Pooja, you are keeping all those patients and reporting to the FDA?
For the expanded access, we would have to report it to Gilead. For the emergency use, we would be reporting it to the FDA.
So Gilead is collecting all the data, but we don't know yet what's the real outcome is. Have they started using this early stage when the patient just comes to the hospital with the COVID?
Yeah, so with the emergency use now, we're able to give it to any patient who comes through the hospital with saturation less than 94% and a positive COVID test. And they also have to have good liver and renal function as a criteria.
So that's hello? Hello? Hi. So our next speaker, can you hear me?
Yes. ఓకే ఒక నిమిషం అండి ఇక్కడ వీళ్ళు ఏదో మాట్లాడుతున్నారు.
Can you hear me?
We can hear you. Hello?
Yeah, Dr. Sinha got muted. He has to unmute himself.
Can you hear me?
Yeah, we can hear you. Yeah.
Yeah. Can you hear me now?
Yes, sir. I can.
Okay. So Dr. Jacatoros, right?
Yep.
Yeah, sorry. So he is a principal investigator for convalescent plasma, and he has quite a bit of experience treating the patients with the convalescent plasma. So we want to hear his experience and the outcome. Yeah, please go ahead.
Thank you for having me, everyone.
Thanks.
At the beginning of this pandemic, my partners and we took over a intensive care unit where we primarily treated very, very sick patients. And it became very clear that the pathology that we were seeing was very extraordinary. And we needed to use all our arsenal to help fight this. Alongside of hydroxychloroquine, alongside of remdesivir, alongside steroids, the next option was the convalescent plasma. So the initial experience that we started with was giving the plasma to the extremely critically ill. And we saw some positive benefits with respect to decreasing their oxygen requirements. However, we saw some limitations in the extremely critically ill. Initially, we have treated approximately about 180 patients so far, and a third of those patients were on a ventilator. What I can say is that what I have learned is early on with anybody that comes into the hospital with hypoxia or shortness of breath and is on a non-rebreather or high flow has the very real capacity to deteriorate very quickly and easily end up in a very critical situation. So what we initially started off with treating the very critical, we then transitioned to treating the moderately ill, and as well then this person that would come in straight away to the ER that needs the extra supplemental oxygen. And what we saw in those patients, in the early patients that come in, they have almost like a dose response. There's a certain viral load that each person uniquely has. Currently, the plasma that we obtain from the various blood centers, at least within our tri-state area, we can't quantify how many antibodies there are in each bag. So what we initially did was started off treating with one bag, which is approximately 200 mLs of plasma. And we were seeing, for the most part, very good response in the unintubated patients. Because within approximately 2 to 5 days, you would watch the oxygen requirements, and I continue to see this, the oxygen requirements improve. However, sometimes they had a recurrence and their oxygen requirements and their infiltrates on their X-ray worsened. From these early patients, we started to say, well, we need to do a little bit more because we're probably fighting against a higher viral load. And the neutralizing passive immunity provided from the plasma, we would concentrate that by giving a second unit. So our typical treatment regimen is to give plasma over a 2-hour period without any pre-treatment. Then we would follow that after 10 hours and give the second unit, again over 2 hours. Of the patients that we've treated, none of the patients have been pre-treated with steroids or Benadryl, and no one has had a reaction. What I talk about possible complications with the patients and their families are possible allergic reaction, possible fever, possible acute lung injury, a possible thrombotic complication. As we know, the COVID itself is very prothrombotic. We also talk about that it's an experimental treatment and it may not help them. As of late, the Mayo protocol has allowed for multiple plasma units to be used. But right now, what I have seen in our limited experience is that the improvement can occur within 2 to 5 days. However, they can stay in the hospital longer. And we have to stay on top of these patients and monitor their oxygenation. Some unique findings are not everybody presents with respiratory symptoms. What lately we have been identifying is that there's primary GI complaints, nausea, anorexia, diarrhea, and uniquely we may find abscesses in the intestines, we may find ischemia, and more often than not, these patients are left alone and they progress into respiratory failure. The other part of this is that in order to participate in the Mayo expanded protocol, you must be positive for the SARS nasal PCR. However, not everyone is positive on presentation. There are at least 10 cases that we have had where if you look at the ferritin, the D-dimer, the CRP, the LDH, and you look at their clinical course, it is all consistent with a COVID infection. However, a PCR or multiple PCR nasal swabs can be negative. Other people from across the country have seen this very similar thing, and they have identified the PCR from endotracheal aspirate, or they do bronchoscopic aspirate. However, we also apply through the FDA for the ability to give plasma. And in these patients, we definitely have seen an improvement following the convalescent plasma usage. So not everybody that tests negative, that does not mean that they do not have the actual COVID infection. It just means that we haven't actually identified where it's concentrated. Looking at the combination, we also have a lot of overlap with patients that receive tocilizumab as well as remdesivir. So far, the overlap appears to be safe. However, we try to space out the treatments so that way we know what is clinically improving the person and what may be negatively harming the patient. Looking at the course of our patient, I can imagine a treatment paradigm where somebody comes into the hospital and advocating early usage of the convalescent plasma, and then followed by a second dose, complemented by remdesivir, as well as, if needed, the tocilizumab. But there are multiple different treatment paradigms there. But overall, the convalescent plasma appears to be safe, tolerated well, and it's very promising from a treatment standpoint. But you have to know that there are limitations and you may need multiple plasma units.
Hello.
Yes, sir.
Oh, very good. Thank you very much for such a good presentation. I will have questions. Maybe start questions to you. Initially, I was involved in helping the plasma convalescent to the patients. To initially hospitals, a lot of the hospitals in the country, they were not enrolled with the Mayo Clinic trial. So I helped them to enroll in the Mayo Clinic trial, register the patient, register the doctor, and then we had a problem with the bank getting the plasma.
Yes.
Now, things has gotten better. I had about 15, 16 patients in New Jersey that I had to help and talk to different blood bank. But now I think it's easier to get plasma.
Yes, initially it was very stressful because
Yes.
you would only get about 3 or 4 plasma units allocated to our facility. And the persistent conversations, we were able to lift the limitations, and the plasma volume definitely caught up to the demand.
Mm-hmm.
So it's gotten better.
So it is easier now to get a plasma after they do the typing, biotyping. And it has become much easier. Now, has Mayo Clinic has changed their protocol? My feeling was, although I have not treated any patients, but my specialty is different, that these treatments should be started very early when a patient comes and getting sick before the patient gets into the ICU and intubated.
You're absolutely right. I think what we all have learned is that the early treatment, the better off for those patients. As the moment that person gets intubated, their mortality significantly increases.
So you have a good feeling that this May, we don't know the trial. Where do we stand on this big Mayo Clinic? They were in charge of the whole country running this trial.
Based on my experience. Sorry.
Do we have any idea where we stand on this trial?
I can only anecdotally tell you from my limited experience of seeing the actual evolution of the patients in the hospital. I see a clinical improvement. And my feeling is that if we catch these people early, the response would be better. And what we were seeing early on, the patients would come so hypoxic, so sick, that they were intubated straight away, that there was no time to administer anything. They were intubated right from the get-go. But I have seen also in certain patients, even in the critically ill, we can stabilize those patients to at least get them to a tracheostomy and a feeding and a PEG tube, have them heal. And I think the patients that form their natural antibodies ultimately do better long-term, because the initial passive immunity from that antibody that's given from the other person allows them to buy some time, their bodies to buy some time to reverse some of the effects. But the way I like to imagine this, it takes a little while for the virus to do all its damage. It takes the equal amount of time, if not longer, for the body to undo the damage that the virus has caused through the convalescent plasma.
But your experience, do you think this is just another supportive care?
I think this is one of the direct treatment options that I immediately first think about, because I've seen the improvement. Because this is virus specific.
The problem is that we don't know the antibodies, what titration. We know that higher the titration, the better better the plasma is, and it works better. But there is no standardized test to tell and check for the antibodies. So whoever has infection, they just go and donate, but nobody knows about these antibodies are good to transfuse, or it's a waste of time.
You're absolutely right. And that's why we have tried working in a collaborative effort with the infectious disease doctors, the pulmonary critical care doctors, our hospitalists, because the moment there's some sort of setback, we try to then work together to then treat more aggressively by giving another plasma unit, because you're absolutely right. That is the significant limitation.
So we have to just wait from the Mayo Clinic report after they have a data of whole country.
Absolutely.
But it is still very popular. It's being used all over. Still, many hospitals are still using plasma convalescent, and then okay. Thank you very much for your very good talk. And all right, let's see. Let's go back to the panel. Bipul.
I have a question about the convalescent plasma. Just like when we treat patient with the exogenous steroids, it inhibits the endogenous steroids production. So when we use passive immunity with the external antibodies, does that have any effect on a patient's own immune system to produce antibodies?
I don't believe it does. And some of the anecdotal evidence that we've given it to people with active glioblastoma, active CNS lymphoma, active lung cancer, active GI cancers, and they have done very well, especially when we give it early in their course. But I don't believe it should limit or inhibit the body's natural ability to form their own innate immune system.
Another question would be, I know initially there was a limitation. If you use the convalescent plasma, then you cannot use remdesivir. Has that changed now?
So with the late stage, initially with the late stage, Dr. Shah and I, we would balance it out because the remdesivir, Gilead did not want to have the convalescent plasma overlapping and done in parallel. So you either had to do it before or you had to do it after. What I have learned, it's probably better to do it before, especially in those late stages. But now we have had a few patients where we actually give the convalescent plasma, wait about 6 hours, give the remdesivir, then the next day, 10 hours later, give the next, the second unit plasma. And they've done pretty well.
As the time goes, it might be interesting to look at the data of patients who were treated only with convalescent plasma, patient who was treated only with remdesivir, and the patient who was treated with both, if there was any outcome differences between the three groups.
You're absolutely right. And it would be amazing if we received the antibody level in each plasma unit from each blood center, but I don't think that they have that kind of quantifying data yet.
Okay, I have a question. Go ahead.
We would like to invite more questions. A lot of speakers may not have much experience, but even I have not treated a single patient of COVID-19 myself, but you use your inquisitiveness to ask questions.
Well, I have a question for Pradeep Shah. Pradeep?
Yes. Yes, go ahead.
Quite a few questions here, but what kind of standardized testing are we doing to detect antibodies?
Okay. I think the one we use here is called ROS, antibody testing, ROS, and it's very good testing. Usually they're doing IgG. The purpose, you have to understand what stage of the disease you are going to do the testing. That is the first thing you have to understand. And the second thing is, if you are just checking that patient had infection and now has antibody or not, because people want to know that whether they are immune, which is not a right word to use, immune, because we don't know what is the cutoff level is. But the idea for anybody to do antibody test is a patient who had a disease, they want to see they build up any immune system or not within that. So there are different labs available. The one we are using here is a ROS, and I think ROS has been pretty good for IgG,
Wow. Okay, thank you very much. There is another question for Pooja. The remdesivir still is, what's the availability? It was difficult to get. There was some problem in availability of the drugs, and what is the status now?
So now the availability is through our FDA through emergency use remdesivir. So the government through FDA has decided which hospitals need remdesivir based on, I guess they were seeing which ones had the highest population of COVID patients, which hospital had more patients. So to my knowledge, initially FDA was picking hospitals around the country, and eventually they were giving it to more and more hospitals. I know New York, New Jersey has remdesivir. It's available for us up in the New York, New Jersey area. As for other states, I know I have a friend out in Nevada told me their hospital was able to get remdesivir through emergency use. So I think it's more available to different hospitals, but it's all decided by the government through the FDA right now.
Is there any? Okay, go ahead. Go ahead, Pooja.
The good thing with the emergency use of remdesivir, the criteria is a little bit open versus the expanded access was only for intubated patients. Now, emergency use, you're allowed to give it to people who come through the hospital with a low oxygenation of 94%, which I think is a better option because you want to try to get to these patients early. Like Dr. Zachariah said, early on, we can try to give all the treatments, the better for the patients.
Now, the other question, Pooja, for you, that the FDA has approved to use both remdesivir and plasma in the same patient?
Yes, like I think the thing is with the whole treatments for COVID, Dr. Zacharias and I have been working together. We try to space things out. We can give patients plasma, we can give them remdesivir, and we also do tocilizumab, which is an IL-6 inhibitor, if we think that is needed to help prevent the inflammation in these patients. And what we try to do is keep it very, very spaced out because you still don't know the interactions between plasma, remdesivir, other treatments. So we're still learning as we go because everything is still, as we do things, we learn different outcomes and different side effects. So we try to give everything, but in a timely manner.
Okay, so there is still a problem. One comment came that remdesivir is 800-bed hospital, and they had allowed only for one patient only. So it's still not easy to get remdesivir on patients that the doctor wants to use. So that is still an issue in some part of the country.
Yeah, I believe that it's all determined by the FDA. They are the ones that are trying to figure out which hospitals need it or not. There's no control from our end. This was all set by the FDA. They are the ones who decided. So I'm not sure about other hospitals around the country, but I just know up in the tri-state area, at least up here, we were able to get remdesivir. Initially we weren't, but then down the line, they were opening up more and more hospitals by the FDA. And I think it's based on the volume too.
One more question for you. You have been involved with remdesivir. and also in the convalescent, what is do they really help the patient to leave hospitals early and stable condition than patients who didn't get these two treatments?
You know, we saw a lot of patients here, and we had a lot of, it's hard to say. I think in some patients, both the plasma and the remdesivir did help them, and in some patients it did not help them. It all depends on their status when they came through the hospital, how sick they were, because when you have the very, very sick patients that are on the ventilators, their mortality goes up. And so we try to give them all the options. It gives the families that feeling, at least we try to give them everything we could to help save their loved ones. And that was a lot of our challenges here. We didn't know what was working, what's not working. And I think in some cases, the combination is helping. Some cases I had patients just get only plasma. I had patients only get remdesivir. So it was all a mix to see. And this is something down the line we can analyze our data to know, because everything we did is whatever we could do to help save these patients.
Oh, thank you. Thank you. Pradeep,
Yes.
we have a question for you.
Okay.
Between the nasal swab and the sputum test,
Yes.
if you have to use, which one you will use, which has more specificity and sensitivity?
Very good question. The way it is the sputum is considered little better specimen in the sense that because it's involved the upper respiratory and the lower respiratory region, so it gives you more specimen is better. But even if you do the nasal swab, if you do properly, and if you have symptom, I think both are equally sensitive and specificity. But it also depends on how patient present also. If a patient who has a shortness of breath, fever, and cough, the sputum will be a lot better. But if patient who has a anosmia, which is the not smelling, and the taste also they don't have it, so the nasal swab will be better. But I think both are now, we have seen that both are coming out good, as long as you do the properly. See, the word is the properly collected specimen is very important, in that.
And how many days it takes for nasal versus sputum to get their result? Because there was a criticism taking so long. By the time patient can have infection, it may be a negative one sample and 3 days, 4 days. So how long it is taking now to get the report on those tests?
Okay, there is a one called the very quick tech. We can get it in 20 minutes if somebody can do it in front of you. So the reason we were getting delayed testing result because we were overwhelmed. There were thousands of specimens, and to run this test is not easy initially. So it was time consuming to do the testings and all that. That's why it was delayed. But nowadays, we are getting some of the rapid PCR tests, which comes in 20 minutes. We can do it in the hospital, okay? And some take 24 hours if we send it out to the Quest, because by the time they collect the specimen, it goes to the labs then send it out, then the Quest or the lab coat, they run the test, and they have thousands of specimens. So they don't run one by one, they run one by one. So that's why it's getting delayed. But the most of the tests can be done very easily. And earliest I've seen report is in half an hour, I have seen whether it's positive or negative.
The other question, Pradeep, that any other secretions in the body fluid that can be used for testing?
Saliva, sputum, and nasal swab. That are the three one used. We have not tested any urine or stool. I mean, we can do the PCR on the stool, because the people who presented with nausea, vomiting, I'm not sure they have done it or not. We have not done yet so far, But that's one possibility. If patient present with the principal symptoms of the GI, nausea, vomiting, or diarrhea, we can do the PCR on the stool, if it is diarrhea. That is. It is excreted in the stool, definitely, we have shown that. So that can be done.
Okay, that was good. one more other question was again, this is for Pradeep. For asymptomatic patient, how frequently a test should be done who has no symptoms and is negative?
Okay. The asymptomatic patient, which are very challenging patient, the reason the person will do asymptomatic will, obviously they don't know whether they will, but with the curiosity and the panicky, people want to know whether they came across somebody, and even though they don't have a symptom, they get very panicky. So they want to
Right.
do the testing. Okay.
Right.
The other one is they just out of curiosity, they want to know whether I have disease or not, So, and to say the asymptomatic patient, let's say a patient does the testing today and is positive, but is asymptomatic. What is advised is usually they should be isolated 7 days, and then 3 more days of asymptom. If he remains after 7 days, for 3 more days without taking antipyretic, no fever, no cough, no shortness of breath, they don't need to do the testing because it's considered that they are non-contagious. Now, in a positive patient, usually asymptomatic, still it is advised that we can go for 14 days of isolation and 3 more days of asymptomatic. Then they should be come out of the isolation. That
Okay.
is what we suggested. But this is all evolving. As you know that the WHO came out with the new thing, but I don't want to go in detail right now.
Yeah, that's okay. Well, thank you very much for all of you to coming this evening, taking your time off. You did such a good presentation. I thank everyone on the panel, Pooja, Pradeep, and Dr. Jikar. Very, very good, excellent. And I think Suresh ready there to come. Suresh ready?
Yes, I'm here.
Okay, please.
Hello.
I think
Yeah.
we are done with the questions and answer, and I want
Thank you so much.
he's our
Thank you.
president. Suresh Reddy is our president of the API. He's the most dynamic, most young, most good looking, and my favorite president. So I want to see what he has to say.
Thank you, nice of you. And thank you, Dr. Shahs and Dr. and Vinith Pulkabaria and Dr. Sinha for this amazing plasma. Second, and also I have a couple of videos I want to run it. Let me. API is one of the first organizations we kind of went aggressive on plasma treatment. We formed 3 committees, one for collection and delivery of the plasma. Second one is working at the higher ends. We wrote letters to all the senators, congressmen. This was almost 2 months ago, and to put pressure from the legislative side. And we also had another committee who works with the hospital administrators. So there were 3 layers of attack, and it was like a 3-prong attack. And I will show you a video when we release that at the time. Can you see the video?
No.
Are you able to see that? No?
No.
No, just see your window. So please
What
turn
about
it
now?
on.
Now?
Not yet. Is it playing on a different monitor?
Should be. So you cannot see the video?
No.
What about now?
Now it
Yes.
is, but no sound.
You have to start the video, yeah.
What about now?
No, it's still not.
Not able to see the video or no audio?
No video.
No video, no audio.
Both, yeah.
So
It's all right.
it's all right. Okay. Sorry,
I think
we
that,
have some
that one
technical issue.
we have sent it to a lot of the doctors, yes. I remember that one.
And what about now?
Only video, no audio.
Oh, I'm sorry. Okay, I think there's some issue. Okay, so there is another promotional video. Can you see this one?
Yes,
Okay. So
but
we.
no audio.
Oh, I'm sorry.
No
So we
audio.
have entertainment scheduled for at 9 o'clock, at 10 o'clock Eastern. We have Anuradha Podwal inaugurating the session, and followed by Preeti Bala. Please join us, and there should be an email in your mailbox with the links on the Facebook and YouTube. Please join us at 10 o'clock. Thank you.
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 Hello.